Hello and welcome to a special interview for The Wire. Once again, COVID cases are rising, and although the government has said people over 60 and those over 45 with comorbidities will receive vaccines from Monday, vaccine hesitancy is worryingly high. Those are the two key issues I shall raise today with the President of the Public Health Foundation of India and one of the country's eminent cardiologists, Srinath Reddy. Dr. Reddy, do we have a credible explanation for why COVID cases are suddenly rising? Or is it the case that just as we were not fully sure why they were sharply coming down despite winter, the festive season, state elections, and farmer protests, so similarly, we're not exactly sure why they are beginning to steadily creep up again?
We do not know for sure, but it's very clear that there has been a certain amount of laxity in the manner in which we have observed the precautions that have helped us so long, even if they were partially implemented earlier, in terms of preventing large crowds and in terms of personal precautions like wearing masks regularly and in the proper manner, and of course, in terms of trying to maintain physical distancing to the extent possible. I believe the feeling that we have already passed the crisis, and not only passed the crisis, but emerged completely out of the epidemic and acquired herd immunity on a large scale, led to a great deal of relaxation at the personal level and even at the enforcement level. And if we open the gate wide enough, the virus will certainly spread. The mutants coming in will need to be studied, but right now there is very little evidence to ascribe the rise principally to the mutants.
Can I come to the mutants in a moment's time? First, can I ask you this? Are you worried that we are seeing the beginning of a second spike? Something that potentially could become as serious as what Europe and America have experienced? Or at this stage, would that be an exaggerated conclusion?
I would say there is definitely room for concern and definitely for action. Whether that worry will actually come through into a crisis of a large second spike with considerable amount of fatality or severe disease and pressure on the hospitals remains to be seen. It entirely depends on three things. One is, what is the behavior of the virus in terms of the mutants? What is the behavior on our part in terms of trying to contain the spread, even if there are mutants? And third, how quickly can we roll out the vaccine in order to provide protection to the vulnerable, at the same time, try and use it as much as possible to contain the transmission itself, to interrupt the transmission chain.
Let's first take up the behavior of the mutants before we come to the rollout of the vaccine. And let's start with the ones that have come from abroad. According to the latest information available from the government, we have under 200 of the UK variety, we have under 10 of the South African variety, and just about one from Brazil. How much of a concern are these foreign mutants?
Well, we know that the concern arises because of their ability to spread faster than the previous version of the virus. And we also know that these are the cases that have been identified in different states through genomic screening, which began after December. We do not know whether some of these viruses, which have acquired the mutant form, have even entered earlier and have actually established their presence elsewhere. While we are certainly keen on trying to detect the mutants now through the consortium of genomic screening laboratories that has been established in December, we still have to be fairly sanguine about the fact that there may be more than the 200 cases that have been reported. But how much they will actually spread and replace the current dominant strain depends entirely on the opportunity we provide to the mutants to spread. And that is where our maximum action must lie.
But you're making a very important point. We began genomic screening for the UK variant and thereafter for the South African and Brazil after December. We don't know, therefore, whether the UK variant had entered our population prior to December and established itself in some areas. That is something about which we don't have clarity at the moment.
No, we do not. And it's important for us to try and do a little more of the screening of the new cases to ensure that we try and detect it as much as possible, but also look at the cases who are coming back with reinfections. People who actually previously were infected, if they have not retained their immunity against the new variant, then that will give us a clue that this is becoming dangerous in terms of its presence and spread in our country.
But it also follows from what you're saying that just because the official number, and I underline that word, official number of UK cases is under 200 and of South Africa under 10, that doesn't really mean there may not be more that we're not aware of. It could have slipped in, it could have established itself in pockets of the country. We just don't know. We need to test to find out.
We don't know either way, but we still need to maintain our precautions because even if it were a mutant that spreads much faster, if we observe all the precautions, then we can still contain its spread like we did the spread of the previous virus version.
Absolutely. Let's then come at this point to the Indian mutant strains. I'm talking of N440K and E484Q. Are they of greater concern, or are you reassured by the fact that N440K has been reported 13 times between May and September 2020 in Telangana, Andhra, and Assam, whilst E444Q was detected 4 times in Maharashtra between March and July?
Well, it has been clarified or at least reassuringly stated by both the Director General of the Indian Council of Medical Research as well as the Niti Aayog member for health, Dr. Paul, that these mutants have actually been around since March last year, some of them, and they have been detected at various points in time last year, but they were not known to be more infective than the other versions, and certainly not more virulent than the other versions. So in that sense, there has been a communication of reassurance that these do not pose the same level of threat of higher spread or higher virulence as compared to, for example, the South African mutant or the British mutant. I would like to avoid the names of the countries because that's pejorative, but still, unfortunately, till we get better knowledge, some of these numbers can be a little confusing for the viewers.
Can I put this to you? The British variant was first discovered as far back as September. But it was only in December when the British discovered that actually it was the variant that was increasingly spreading, and it was spreading far faster than the original strain. So just because something was discovered 3 months earlier doesn't mean, given time, it may not actually begin to spread in a much faster way. Could that be a potential, I underline the word potential, danger we should be aware of with regard to the 2 Indian variants?
Entirely, I agree, because in Britain too, not much notice was taken of this till the cases started going up again. So the feeling that they had overcome the problem and the sort of satisfaction they derived from the fact that their vaccines were already on the way suddenly gave rise to alarm when the cases started going up, and then they noticed that this mutant was actually now spreading much faster. So we do need to look at whether our spread is being contributed to by these mutants in a much larger measure than has been currently stated. Of course, that is something that we need to find out only by studying a larger number of people who are coming up with new infections. However, I would still maintain that the precautions against the mutant virus as well as the previous virus strains will still remain the same, and that is the public health message that must be repeatedly emphasized.
Okay.
If your batsman's defense is strong, whether the swing bowler is bowling swing from the offside or from the other side, it doesn't really matter.
But you're also saying that although it was reassuring to hear both Dr. Bhargav and Dr. Paul say that both these Indian mutant strains have been around for several months, nonetheless, we need to keep testing, because just as in Britain, after 2-3 months, the British strain began to spread rapidly. That could happen, and we need to ensure we're on top of it. So testing and keeping yourself alert is critical.
Well, to borrow a phrase from the Comprehensive Test Ban Treaty, trust but verify.
Absolutely. Against this background, Dr. Reddy, are you satisfied by the vaccine rollout that began on the 16th of January and has now been continuing for the last 6 weeks? Or are you concerned about what the Hindustan Times reports today, Saturday, the 27th, that on average, the nationwide uptake of vaccines is just 48%? If accurate, that suggests that a majority of people who are entitled to the vaccine haven't taken it.
Well, I believe we do need to step up our vaccination program. Now, of course, they're planning to increase the number of vaccination centers from 12,000. Previously, it was 10,000 in the public sector and 2,000 in the private sector. Now they're planning to make the private sector centers about 20,000. So the centers will go up. But that's the supply side. We need to ensure that the demand side problems are addressed, which means greater vaccine confidence as well as greater ease of access to the people who want to take the vaccine. And that needs to happen at the actual mohalla level, at the village level. And it can't happen entirely through an app, however easy it is made. We do need to make it much more easy for people with or without access to the smartphones to be able to register, get their priority, the status checked, and get immunized as fast as possible. So
let me pick up on this last point you're making, because I think it's very relevant to the plan the government has to start vaccination for the over 60s from Monday, as well as for people over 45 with comorbidity. As you and I speak on Saturday midday, there are just 36 hours to go before Monday starts. And yet, the COVID app is not available. Most private hospitals, and I've checked, don't have an idea what they're expected to do or what the registration process is. Most individuals are not aware of it, although it's been discussed on television interviews and in newspaper interviews. But the general public is utterly unaware of what the procedure is. So can we really start in 36 hours? Or do you think Monday is bound to slip by 3-4 days till the system is up and people are informed?
well, I think on Monday, the app will become publicly accessible. And then the registration will start. You may not get a large number of registrants getting immunized on the same day. But I believe having the walk-in centers also available would be very helpful in the initial stage till the app itself is substantially subscribed to. But as I was saying, it is not just enough to depend on the app. I mean, we have had immunization programs. There was mohalla by mohalla identification and also providing access through community-based worker support. So our primary healthcare system, our civic volunteers must step in to try and identify who are the 60-plus-year-old people, who are the other people who qualify. And then as the age also comes down closer and closer to 45, then we need to identify them as well. I think it now becomes much more of a community-based effort as well, not merely a facility-based effort.
So you're saying two things. Firstly, you're saying that the expertise that we have and the experience we have through earlier inoculation campaigns, using ASHA workers, using health workers to actually reach out to the people who need to be vaccinated must be utilized. Don't rely on people themselves going to the app or knocking on the door of hospitals. Reach out to them just as you've done with earlier vaccination campaigns. Am I right? That's the first thing you're saying.
Yes, that not only helps to educate people about the availability of vaccine, but also helps to overcome vaccine hesitancy. Because large number of doubts that still linger in people's minds is based on uncertain or poor information. And if we can actually get community networks to address that, even that barrier would be overcome.
The second problem seems to be that a lot of large hospitals, also some medium ones, that are bound to be involved in vaccination are utterly unaware of what they're supposed to do. I've spoken to a couple of doctors, both last night and this morning, and they say they're still waiting for guidelines. They're still waiting to find out. They don't know whether they will be receiving the vaccines from the government or whether they have to buy them. They don't know what the process of registration is. So even doctors who are contacted by people like me because we're anxious, we want to take the vaccine, have nothing to say. One doctor said to me, he's received 20,000 inquiries, including from his own staff, but doesn't know what to say because he doesn't know anything more. And yet, officially, this is supposed to start in 36 hours.
Well, I do not know what exactly is happening over Saturday and Sunday and how much of communication will actually reach out to the various centers and how much of logistics would be worked out in terms of supply. We'll have to wait and see. And there could be some delays, I believe, but we must try and ensure that these delays are minimal and the rollout proceeds smoothly, because otherwise that too can be a barrier in building up vaccine confidence.
But in a nutshell, before I move on, making sure that vaccination for the over 60s as well as the over 45s with comorbidity happens smoothly, happens effectively, and large numbers, and that's very important, large numbers take it, is a very big challenge for the government. They may not succeed in putting it off in 36 hours. That's understandable. It wouldn't be a crisis. They have to make sure that by the middle of next week, the system is up and working. This is the challenge. Am I right?
Yes, entirely. And therefore, I emphasize the fact that we need all hands on deck. The private sector has been brought in, and I hope they will come in a very responsible and sufficiently supportive manner. But we also need to bring in the NGOs, the community-based organizations, the citizen networks, unless it becomes that kind of a mass engagement, what I would always call a people-partnered public health. It's not going to really take off in a big way.
Okay. Let's then come to another aspect of the problem we face. It's a combination of the fear that we could see a second spike, along with the very high and worrying vaccine hesitancy that we're witnessing. Given these two facts, do you think the government should accept the WHO guidelines officially announced on the 10th of February that the interval between two doses of the AstraZeneca should be increased? At the moment, the Indian government is giving the second jab 28 days after the first. But the WHO on the 10th of February has officially said that in fact the second jab should be given somewhere between 8 and 12 weeks after the first. If the government were to accept and expand the interval between the two doses, many more people could get one dose much more quickly, and that would give them some level of protection if, God forbid, there is another spike lurking beyond the horizon. So should the government accept the WHO advice?
Well, there is a view that can be taken by scientific orthodoxy, and there is a view that can be taken by scientific sensibility and operational feasibility. The first one would insist that you must have a vaccine rollout program which mirrors exactly the trial protocol. The trial protocol in India was of 28 days and of 2 full doses. Now, if you say that that's exactly how the rollout must happen in India, then of course the conventional system must be followed. On the other hand, the WHO relied on evidence that emerged, even somewhat circumstantially or serendipitously, that as was said, of a smaller strand of the AstraZeneca vaccine trial, which actually showed that in 3 months, the immunization efficacy was much better, and also depending upon the immunogenicity studies themselves, and saying that 8 to 12 weeks is fine. And some of the countries are now beginning to do that, and Britain, of course, set the trend. It's possible that if we take all the evidence that is available with us to make that judgment call, like WHO did, we too can go in for an 8 to 12 week interval and immunize more people.
Dr. Reddy, let me put you on the line. You are president of the Public Health Foundation. What is your advice to the government? Stick to 28 days or follow the WHO's advice and expand the interval to somewhere between 8 and 12 weeks, primarily also because if there is a second spike, you want to ensure the maximum number of people have at least one jab quickly, and this will facilitate that. So what is your advice to them?
If there were no pandemic, if our cases were fully contained as in December, I would have said play by the rule book.
But now,
given the fact that there is an international consensus steered by WHO that 8 to 12 weeks is all right, and there is a concern that the cases are rising, a large number of people who are vulnerable are at risk, I believe we should take commonsensical but relatively well scientifically backed recommendation for 8 to 12 weeks.
So in a nutshell, you're saying expand the interval to 8 to 12 weeks. That is what you're saying, isn't it so?
Yes, yes.
That's very clear. Your advice to the government as president of the Public Health Foundation of India is expand the interval between the two AstraZeneca jabs to somewhere between 8 and 12 weeks as the WHO has advised. Let me come to another issue. Given that we have clearly identified the districts where the number of cases is worryingly increasing, should the government, in addition to the present calibrated nationwide rollout plan, also intensely focus on these districts? Let me use that colloquialism. In a sense, carpet bomb these districts with vaccinations so that everyone there gets it. Would that be a sensible thing to do alongside the nationwide rollout?
Well, the two principal objectives of immunization are to protect the vulnerable, apart from the essential health workers and other workers, and then try and contain the transmission. Certainly, in the districts where the current spread is quite rapid and large numbers are getting infected, the people who are vulnerable will be at a greater risk. And secondly, the risk of transmission also is because of that. And therefore, increasing our effort in those districts, particularly to protect the vulnerable, and simultaneously try and increase the overall level of vaccination of the other groups as well, so that we can contain the transmission, would be the appropriate strategy. That should go alongside the rollout based on the current criteria in other parts of the country. But where the fire has now suddenly grown larger, we certainly need to send more fire engines.
Absolutely. So we need, alongside the nationwide rollout that is happening, to concentrate in a very in-depth, focused way on the districts where the numbers are increasing worryingly. I use the phrase carpet bombing simply to suggest that you needed to intensify effort and make sure that you reach everyone. Let me raise one more concern with you. You're well aware that many European countries are expressing concern about the efficacy of AstraZeneca. Germany and Denmark have decided not to give it to people over 65. Spain, Italy, and Belgium have decided not to give it to anyone over 55. Switzerland is not giving it at all. Side by side with this European concern about AstraZeneca, there is also the fact that both Pfizer and Moderna have established quite a good reputation for themselves. That being the case, should the government permit Pfizer and Moderna to be sold privately in India so that those who want can take it? I'm not saying in place of, I'm not saying by disrupting the national government's own plans, but in the private market for those who want it.
Well, Moderna has not even applied for permission. Pfizer has, but then withdrawn. It may go back again seeking permission.
Can I interrupt?
But
Why can I?
Yeah.
Pfizer withdrew because they were asked to do bridging studies in India. AstraZeneca, as you know, hasn't even finished its bridging study. AstraZeneca got its clearance on the basis of the trials that have been done overseas. If that can be used for AstraZeneca, surely the same could have applied to Pfizer. Rather than say to Pfizer, do your studies in India and then come back, we could have said, just as we've accepted AstraZeneca on the basis of UK and Brazil studies, we'll accept you on the basis of your foreign studies. And given that Pfizer has a well-established track record that people are acknowledging internationally, should we not at least permit Pfizer to sell private?
Okay. On the Pfizer issue, let me try and pose a few questions and answer them. There are questions related to science and questions related to policy. On science, I believe your statement is absolutely right, that given the global track record of Pfizer in terms of proven efficacy of a high order, and even a higher order than seen in the trials as being reported now by the overall experience from Israel, there is no doubt that the Pfizer-BioNTech vaccine is very, very effective. against the disease. And now there is recent evidence emerging that it is also effective against transmission and reducing the transmission. This was not answered earlier, but it's commonsensical that if you're limiting the disease, you're not going to get too many people discharging the virus in large numbers into the environment. But second question is it safe? Yes, in the short term, it appears to be safe despite the initial anaphylactoid reactions being reported, after which they said anybody with severe allergic disorders should not take it. They were concerned about elderly deaths in Norway, and that was considered to be because of frailty rather than because of the vaccine itself. That's how the Norwegian government explained it, but we'll still have to worry about whether 80 plus people or 90 plus people should get it. We do not know the long-term consequences, but we do not know about the other vaccines either. Is it easy to store and transport? Previously, that was considered to be a very severe barrier because of the -60 to -80 degrees centigrade issue. Right now, they've come down to freezer temperatures. They said it's about -25 to -15 degrees centigrade, whereas the freezer temperature in the upper part of the fridge would be -18. So that problem is taken care of. But there are two other issues. Are the supplies adequate? Doubtful. European countries are fighting over the supplies between Europe and UK and elsewhere. And even within US, the supply chain is not very strong at the moment. The next question is, how much are they really going to bring in? Are they going to bring in for a niche private market in India? Or are they going to be able to supply in large stocks? There is no assurance of that. But the next question is cost and conditions of supply. We do not know the cost that they're going to charge. And I'm worried about the conditions of supply, looking at what's happening in Latin America. Now, in Latin America, they have not only asked for complete indemnification for now and the future, but they've asked for sovereign funds to be committed to cover any compensation costs, that the government must commit its sovereign funds now. And Lawrence Gostin, who is one of the eminent jurists.
You're talking, Dr. Reddy, about what has been reported from Argentina and what has been widely covered by a medical or a journalistic journal. The Argentinian concern is a serious one. What Pfizer did.
Brazil too.
And West, except that now Pfizer is actually available in Brazil, but yes, initially they did create problems. But just to sum up the points you made, scientifically, Pfizer is efficacious and safe. In terms of temperature, it's now easier to handle because they believe that they can be stored effectively from -15 to -18, which the upper part of the fridge can handle. As to the quantity they will give and the price they will charge, that of course we don't know, but we're not saying the government should acquire it for the government's own plans. Make it available in the market for those who want to buy it. Surely that would also overcome hesitancy concerns and also make it easier for those who want to buy it to do so. I'm not saying in place of AstraZeneca and Covaxin, but in addition to in the private market. After all, the BMW and the Mercedes are expensive cars, but the cost doesn't mean that the Indian government doesn't let them sell in India. Right? They're not easy cars to maintain, but that doesn't stop them selling in India. Similarly, apply that principle to Pfizer. It's expensive, but Pfizer wants to sell. Let Pfizer sell to whatever level it's willing to sell, and let Pfizer ensure that they are prepared to sell without setting these demands about sovereign guarantees. Those came into play in Argentina because Argentina was buying it for the government side. Here, if Pfizer wants to sell in the private market, Pfizer can't demand a sovereign guarantee. So don't you think this is something the government should consider?
But for the government, there is also a certain element of equity that they must look at. If the health workers in government facilities say, why are we not being given Pfizer, which is 95 to 99% effective? If the poor and vulnerable people who have a considerable threat to them say, why are we not being given by the government? Why are you only reserving it for the elite? In terms of such public health threats, you have to take into account also the question of equity And of course, you must try and make it as widely available to as many people as possible, not have a few pampered people in a few private enclaves only benefit from the vaccine.
I take your point about equity entirely. It's extremely important in a democratic country, except that equity should also have been a concern when the government was considering Pfizer in the first place. At that point, when they were aware that Pfizer needs temperatures of -70 or -80, and they were aware that Pfizer is very expensive, equity wasn't a concern. They were prepared to consider equity. And in fact, even now, when they've said to Pfizer, go do trials in India, equity is not a concern because they know that the government won't be able to afford it and most Indians won't be able to afford it. So whilst equity is a very important issue, isn't it odd to bring it up at one point and not bring it up earlier? That's all I'm saying. But let's not quarrel over this. I think the point you're making is a good one. I still think that in a democracy, although there are some things that a government cannot afford, those who can should be permitted to buy it. Otherwise, why let the Mercedes and the BMW sell? Those also raise concerns of equity. By no means anyone in India can afford it. My last question, and it's not a political question, although it may sound like it, but I want to say this to you. Given vaccine hesitancy, and I'll repeat that today, Saturday, the 27th, Hindustan Times says that only 48% of people who were entitled to vaccines have taken it, which means a majority have refused. So given this high level of vaccine hesitancy, and secondly, given the fact that the Hindu reported on the 23rd that 90% of the vaccines that have been taken are Serum's Covishield, only 10% are Bharat Biotech's Covaxin, given these two, shouldn't the president, the prime minister, and senior members of the government publicly take Bharat Biotech's Covaxin, A, to set an example, and B, to reassure the country it's fine?
Well, I entirely agree that the people who are actually looking after health, whether it is the director of the All India Institute of Medical Sciences or the DG ICMR or Dr. Vinod Paul, have taken the Covaxin. But it will be very reassuring to have political leadership when it opens up to the non-essential health worker category to take that particular vaccine, especially since the logic of backing Covaxin rests on the emergence of mutants against which it may actually provide a larger antigenic template of immunity than something that is directed only against the spike protein. So, and it's also therefore it makes sense on the and if you're accepting the AstraZeneca vaccine 8 to 12 weeks mainly based on immunogenicity studies, then Covaxin too has passed that test of immunogenicity studies.
I'm coming back to the question I raised. Your answer began by saying it would be very reassuring to have the political leadership take the vaccine in public. I'm repeating it because I think a clear response is essential. Do you?
Yes, absolutely.
Do you agree?
Absolutely. I am a retired professor from All India Institute of Medical Sciences. Once it opens up to the retirees, I would go to All India Institute of Medical Sciences and take Covaxin.
No, I'm not talking about you, Dr. Reddy. I'm repeating my question. Should the president and the prime minister on public take Covaxin, specifically Covaxin, to overcome the hesitancy concern? And let me tell you, in several countries abroad, heads of government have done it. Kings and queens have done it for this reason. So in India, when we know that the hesitancy is now crossing 51, 52%, should the prime minister and president set an example and take Covaxin specifically? Give me a clear answer, yes or no?
Well, the answer is yes, as a scientist and as a public health expert. But I'd like to qualify it by saying that public health also demands that nobody should be compelled to take a vaccine or which vaccine to take.
Absolutely.
I think that individual.
Absolutely. You can't compel the prime minister and president to take a vaccine. But if the prime minister and president decide they don't want to, they'll be encouraging vaccine hesitancy, not overcoming it. And therefore,
then I'll come on your show to criticize that.
But the first half of your answer is critical. The first half of your answer is critical. Yes, as a scientist and a public health expert, the president and the prime minister should take Covaxin specifically in public to reassure people and overcome vaccine hesitancy. I applaud and thank you for saying this so clearly, so forcefully. I hope the concerned people are hearing you. Thank you very much indeed. Take care, Dr. Reddy. Stay safe.
You too.